Greetings and welcome to this new series on Research Oral Pathology 360. Fibroblasts are the architects of the tissue in which they reside that essentially cover almost all the tissues. However, they are themselves dictated and controlled by the environment, the nearby cells and proximity to the surface, such as in skin and in mucosa, the firmness of the tissue, like in bone, elasticity and strength, such as in ligaments, and unidirectional load bearing abilities as required in tendons, which all of this makes fibroblasts very fascinating. And to add to all of this, they have the phenotypic variations, which are such as the persistence of fetal phenotype in oral fibroblasts. Now, all of this makes it very interesting to me, and I guess that's part of the reason this was chosen. So, I'm Dr. Mandana Donahue, and it gives me great pleasure to introduce our guest speaker for today, Dr. Gopu Sriram. And he is originally studied here, and he's going to be covering cellular aging of oral fibroblasts in matrix organization. He's done a lot. He's finished his PhD after finishing here. This is his very short CV. You can find a lot more detail on him if you go to LinkedIn or his university site. He is Assistant Professor, Faculty of Dentistry, National University Center for Oral Health, Singapore. He is the Trust Co-Lead Dental and Craniofacial Applications, Center for Additive Manufacturing. And he is the co-founder and scientific advisor for Revivo Biosystems. He has got the multi-scale oral and craniofacial tissue regeneration using next-generation tools such as microfluidic organ-on-chip, 3D bioprinting, organoids, and stem cells are his special interests. Amongst his many rewards has been the latest one is all I'm going to talk about, and that's the IADR, Southeast Asian Divisional Research, where he's got the category award for basic science research. He's got multitudes of publications, awards, and presentations. So I will not go into all of that. And it's very nice to have you here with us. Welcome, Dr. Gopu.
Yes. Thank you, Dr. Mandana, for your kind invitation and for your kind words. It's just the beginning of a career in research. Trained as a clinician, trained as an oral pathologist. Research is part of oral pathology training, and after that, like it's just taking the lead into research. That's has been the career which I chose for myself, but from a clinical perspective. Yeah, so thank you very much for this opportunity to share one of our recent research on the fascinating cells, the fibroblast. So I will sort of like look in this particular talk, I will just like show the work, how like fibroblasts can be like fascinating in terms of controlling the overall architecture of the matrix around them in the young and the aged states, right?
That's wonderful.
Okay.
So while you set up your presentation, let me also make some other announcement. So we also have with us Dr. Raghu Radhakrishnan, who is becoming definitely an addition to this channel. I think he's going to be very soon my honorary team member, and he is going to help today again since he is here. Very kind. He is going to be helping me with all the questions. He is actually also here because he has a special interest in fibroblast cells. Although I think like me, his interest is more in terms of fibrosis, oral submucous fibrosis. So the periodontal aspect may be a little more new for us. I don't really know about him, but at least for me. We are also supposed to be joined by our former dean and professor, Dr. Guru Rao, who is both a periodontist and an oral pathologist. I don't know if he is still joined us or not. And of course, Dr. Priya is back from her work in her PhD, and I really appreciate the help she does and the contribution she makes here. She's quite a backbone here. Thank you, Priya, for coming back. and joining us. Yes. Okay. With that, and of course, everyone on YouTube, thank you for being here. Please post your questions as we go along, and we will go through them in the order they appear. With that, now I'm going to just hand over to Dr. Sriram. Please start.
Thank you very much. Right. Are you able to see?
Yes, totally. So now I will turn my audio off. If anything, just call out. I will be here.
Okay, sure.
Yeah.
Just trying to figure out a few things still. Like it's okay. Perfect. Yeah, so I'd just like to start with this particular infographic, which sort of like states that almost half of the adults over 30 years have gum disease. And especially if we move on even further to age 65 and above, like 70% of the people have gum disease in some stage or the other, like either from moderate to advanced stages. And especially in this particular age group, what we see is that the wound healing after any periodontal therapy is on the slower side. So the question is like, why is it so slow in this particular age group? That's the question which we are trying to address here, right? So welcome to this research hour in the Oral Pathology Tuesdays. And so we'll look into how these oral fibroblasts are a contributing factor for the age-related discrepancy, right? So let's first start with something which we are very familiar with: skin aging. Skin aging is something which we are all familiar that with age, the the consistency of the skin changes, how it looks, how it feels, and so on, right? And there's a lot of research which has been done, and it's just because it's something which is very visual to us. It has a aesthetic role to play, and it's sort of the lowest hanging fruit, right? And based on this, like, enormous amount of work which has been done in dermatology field, what we know for sure is that with age, collagen and elastin, which are primary extracellular matrix proteins, drop down from age 30 onwards. And that sort of like brings about various changes in the suppleness, the wrinkles, what we see in the elderly individuals, and so on. And that also has implications on how the wounds heal on the skin, right? But compared to that of the skin, oral mucosa is a very special tissue which has this blessing of being able to heal without any scar, right? Like, and that's the biggest blessing for any, not just the oral mucosa. It's for any of the mucosal tissues in our body, and that's the very important. Otherwise, like, every time we are chewing our food, we would be like hurting the mucosa.
Sorry, Dr. Sriram, have you shared your screen?
Yeah, yes.
It's not being seen. Uh, 1 minute. Now try. Has it come now?
Yeah, it is like saying you are scaring. Sorry, you are sharing, and it's on live mode.
Okay, I think just go back to the
Now,
beginning.
now it's seen. Now it is seen.
Now it is seen because it wasn't seen, I think, earlier.
Oh,
It
okay.
was somehow frozen on what I had been sharing. Yeah. Sorry, can you just restart?
All right, fine. Like, maybe I'll start from somewhere here.
Yeah,
Right.
perfect.
How about the audio? Audio was heard.
I think the audio was heard.
Yes, the audio was heard. The
Okay,
screen was not shared.
okay.
Okay.
Thank
Okay.
you.
Maybe like just want to double confirm what screen is seen now.
Right now, you have the screen of the skin aging, younger and older skin.
Okay. Perfect. Perfect.
Yeah.
All right. Yeah. So let's before even we move on to understand what is the impact of aging on the oral mucosa, we'll first start with skin aging, because that is something very familiar to us, right? And then we know that the skin with age, we have wrinkles on the face, and the suppleness of the tissue changes, elasticity is lost, and so on. And that's something which is very well known, very well studied, is because dermatology is way advanced. And the findings which we have, like from these advanced studies, is that the collagen and elastin, which are primary contributors to the extracellular matrix of the skin, is dropping down with age, like from 30 and then like further down, right? But when we go on to, yeah, okay, just want to confirm whether the slide has changed.
It has, Gopu.
Okay, good. Thank you very much. Yeah.
So, sir,
When we compare the skin and the oral mucosal tissues, they are very
Sorry,
similar.
what happened, Priya?
it is blurred, ma'am. In the YouTube, it is blurred. Text is blurred.
Oh, I don't think that can be helped. That may be a problem with the. Oh, 1 second. Let me see if I can do something from this, from here.
Okay on Zoom.
Oh, yeah, it is actually. And the stream health also is quite okay. 1 second, let me. And the stream health also is quite okay. 1 second.
I think like it's because of the
Gopu.
see, I just
Okay, you continue. I will try and sort it out as you continue.
yeah,
you just
yes, I
continue.
just checked that on the YouTube. There is this settings button in which, like, by default it goes to the lowest quality.
Yeah, I'll try and set it. Sort it out as you continue.
Yeah, yes, I just checked that on the YouTube. There is this settings button in which, like, by default it goes to the lowest quality.
Yeah, I'll try and set it. Sort it out as.
All right. Yeah, there are too many audio feedback now coming.
Yeah.
Okay. All right. So, where was I? Yeah, yes, the skin and the oral mucosa, right? Like the oral mucosal tissues, it's a very special tissue that it has this blessing of being able to heal without any scar, right? And that's the beauty about it. Otherwise, every time we chew our food, we would be hurting the oral mucosa, and we will be all having scars in our mouth, right? And that's something I think in certain states it does lose this scarless phenotype, and of course that's something which is very well known for oral pathologists. That's the oral submucous fibrosis, right? And we all know how implications of the scar in the mouth, right? Okay, so with that, like what I wanted to say here is that as such, oral mucosa has a blessed tissue which doesn't have any scar formation. And so we sort of like have this taken for granted that the oral mucosa doesn't age. Even with 60-year or 70-year-old individual having a mouth ulcer, it still heals without any scar. And so that's where somehow it's a bit of a neglected piece of field, where especially for the gingival tissues, because it's not just about the mechanical trauma, it's also about the microbial trauma which happens on, and that's where the aging has more implications on gingival or periodontal health than any other parts of the oral mucosa, right? So with that, just a short introduction on what oral fibroblasts are. We all know that it's a major cell type in the connective tissue, and it sort of provides the structural support, and also maintains the tissue integrity through production of the extracellular matrix, repair, and regeneration, right? And this happens through various cell matrix interactions between the fibroblast and also between other cell types, right? And further, it also has enormous amount of implications on the epithelium, which is above the matrix. And this happens through cell and cell matrix interactions, which are mediated by the epithelial mesenchymal interactions. And further, it have in addition to general homeostasis, the fibroblasts have a role to play in tissue repair and regeneration, which starts from secretion of the matrix, then remodeling it and completely replacing to something which is of the state which is uh, with which the matrix starts before there was a wound, right? And that's the beauty, that oral mucosa, everything is returned back to normal as if there was no wound in to start with, right? But something happens in aging, that especially in the gingival and the periodontal tissues, there's the whole tissue is sort of like undergoes certain changes with age, and the healing is impacted. And if there are quite a lot, in the last 15 years there have been a lot of work which has been done in this aspect, and various research has found that which can be summarized, that aging basically like reduces the number of fibroblasts in the connective tissue. It decreases the fibroblasts have a decreased collagen or matrix synthesis, and there is increased collagen breakdown, right, which leads to wound healing and regeneration being impaired. But this research basically like is more on a quantitative aspect, like how about the quality of the matrix which has been produced, because we know that extracellular matrix are not just some linear fibers, it's basically a network of fibers which are laid down, and it forms the scaffold for the whole tissue, for the cells to move around and communicate with each other. So if the matrix whichever is laid down is not of the quality which it has to be, then whatever response we expect from the matrix is not going to be there, right? So that's the primary interest with which we started to work on, to understand the quality of the matrix which is being produced by the oral fibroblast, right? So how did we start the work is that we had this fibroblast from the young individual from the gingival tissues, and these fibroblasts were cultured through a process called as replicative senescence. Means senescence is basically aging, where it ages because of replication, the telomere length sort of depletes, and leading to aged phenotype, which is basically characterized by lower amounts of proliferation and higher expression of senescence associated beta galactosidase, and expression of genes like P16 and P21, right? And that's what we see here, that the okay, over here I just want to check like whether um, my laser pointer is seen.
Yes, Gopu.
Okay, that's good. Thank you very much. Yeah, so in the young fibroblasts, you see they are much more slender, while the aged fibroblasts, they are much more plump, and they have a lower proliferation, so which is shown by higher time they need for every population doubling. And that's also been demonstrated by the lower number of Ki67 positive cells in the aged oral fibroblast, and the expression of P21 WAFI. Right. So then what we did is like to understand how these oral fibroblasts contribute to the quality of the extracellular matrix production and organization. What we did is we cultured them in the presence of ascorbic acid. And we know that ascorbic acid is why we added ascorbic acid is because ascorbic acid is involved as a cofactor in collagen production and in other matrix production as well. And so we basically cultured them in the same conditions for 5 days in the presence of ascorbic acid, and then we analyze for the extracellular matrix. And before even going further, just want to introduce some of the preliminary work we did first. Is like to understand how to visualize the fibroblast and collagen in a very live state. Because as pathologists, we are very routinely used to looking at fixed tissues, right? And same way as researchers, most of the research happens using cells and immunostaining and so on. So these are all done on cells which have been fixed, but we want to know like what is happening at a very live state. So this also opens up opportunities for live imaging of the tissues, native tissues itself. And two-photon microscopy is one such technique, which is used in some of the advanced clinics in dermatology for live imaging the human skin. And so we sort of adapted this technology for research purposes, and we started to optimize that. First, to visualize fibroblasts using flavin adenine dinucleotide, which is basically a biochemical molecule which is heavily present in fibroblasts, right? And so there is no fluorescent tagging or anything. It's just pure fibroblasts, and these fibroblasts have these FAD molecules within them, and that can be sort of visualized using certain wavelength of light, right? And using this two-photon microscopy. And based on this, what we can see is that at 800 nanometers of excitation, it has the highest signal. And so we sort of optimize that, being the perfect for visualization of fibroblasts. And similarly for the collagen, you can see that at 860 nanometers, you can see the collagen fibers, which is not seen at 740 or 800 nanometers. What you see is just the fibroblasts, but not the collagen fibers, right? Which is very specific at 860 nanometers. And so we sort of fixed that wavelengths for that. Further, we also were inquisitive about what happens to the keratinocytes, and the keratinocytes, they have a lot of another biomolecule which is involved in glycolysis and energy production, which is NADPH, the nicotine adenine dinucleotide phosphate. So this one again, is abundantly present in keratinocytes because these cells are dependent on nutrition by passive diffusion. There is no active supply because there is no blood vessels in the epithelium, right? So their metabolism is completely different from that of the fibroblasts. So keratinocytes have a lot of NADPH, and so we sort of visualized the keratinocytes using NADPH as the reporting molecule. And you can see at that, like at 750 or 760 nanometers, they have the brightest signal. And you can see the keratinocytes absolutely without any markers. Right. So with that, then we did a sort of a 3D imaging of these tissues. And what you can see is that keratinocytes on the top, then the different layers of the keratinocytes. Okay. Something is happening to my mouse. Okay, yeah, so what you see is like the keratinocytes are forming the epithelium on the top, which is in sort of cyan color, and the fibroblast and collagen fibers, they are present in the dermis, and all these can be visualized in 3 dimension, and what we call this as label-free optical biopsy. Without really needing to take a punch out of the tissue, you can visualize them in a native state. These cells are all live, and which means we can just keep coming back to them again and again. Right. So with that, what we did is visualize the collagen, which was laid down by the oral fibroblasts, which were in the young state. And okay, so in this particular video over here, what you can see is the collagen, which is seen from the top to the bottom. And as you can see in the video on the left, the collagen fibers laid down by the young fibroblasts, they are all running around in all different directions. They are not just in one particular direction. They are forming a network. While that of the collagen, which is laid down by the aged fibroblast, they are predominantly lined up in one particular direction. Right? Like they are much more linear. So they seem to have lost this ability to form these network. So this is what we were talking about as the quality of the collagen, which is being laid down. So if you see this particular panel, each of these panel of image has been captured at different depths, and the depth and the difference between each of these panel is around 2 microns. Right, so starting from 1 micron over here to all the way 29 microns, right? So what you can see is the collagen, the thickness of the collagen matrix is much thicker in the younger fibroblasts compared to that of the aged fibroblasts, right? So that's what we quantified, that the overall matrix thickness is less in the aged fibroblasts, and that there is some issue with the organization. So we went on to quantify this, the organization of these fibers by studying the alignment of each of these collagen fibers across the whole depth. And what you see in these heat maps is this red area represent like where the predominant amount of collagen fibers in that particular degree, like from 0 degrees to all the way to 180 degrees, right, across the different depth. And white areas means there is nothing there in that particular degree of orientation. So in the younger fibroblasts, what you can see is that the collagen degree of the degree of orientation of the collagen fibers, they are distributed all across, right, and across the depth, and all across from 0 to 180 degrees. Whereas in the aged fibroblasts, it's all in predominantly one single very narrow range of orientation. So that sort of like quantifies the amount of loss in the networking of the collagen in the aged fibroblasts, right? So from there we went on to also understand how this could impact other extracellular matrix molecules like fibronectin and fibrillin, which are one of the early molecules which are laid down during wound healing. Right, so what we see is like this is like done using immunostaining rather than by live imaging. So you don't see much of a difference in the matrix thickness between the young and aged, is because after fixation everything, all the tissue just contracts, and so we basically lose that particular information of real live tissues, right? So that's also the reason why live tissue imaging really like helps. Right. So other than that, when we come back to this particular image, what we can see is that again, the aged fibroblasts, the fibronectin, which is laid down by them, they are much more linear compared to that of the younger fibroblasts. We again like quantified that. What you can see is that we sort of like deconstructed the whole matrix into top to bottom layers. The bottom layers represent the matrix which is laid down first and being matured over time, and the top layer is sort of the most recent layer. So what we can see here in these panels of figures, as well as in this particular video, is that like the top layers, which is the younger fibronectin, they are all in a linear fashion. But as it matures down, you can see them, it's getting more complex in a interwoven network, right? And that's also seen in this particular analysis, where like it's all like predominantly oriented in one particular narrow range, but in the lower depth, you see that they're all distributed all across, right? And then when we go on to the aged fibroblasts, you see that heterogeneity between the different layers, or the maturation of the fibronectin, is sort of lost with depth, right? Like, so it's all like sort of like probably just in the immature state, which means the fibronectin is laid down, but the remodeling of it doesn't really happen, right? And that sort of like is also reflected similarly in the fibrillin, which also shows a similar pattern, that it's all like reflecting that the linear fashion of arrangement of the fibronectin and fibrillin fibers, right? So overall, what we can take from this is that with age, the amount of extracellular matrix which is laid down is sort of impaired, and the organization of the matrix is sort of like lost, or probably just stays in a very immature state and doesn't really remodel that much, right? Or probably require much longer time. So this particular experiment was done only for 5 days. Probably if we extend it for a longer time, we would be able to see what happens over time, right? So parallelly, what we were interested is like what happens like if this the matrix, which is not of absolute quality, and what happens to the epithelium which is growing on top of it, right? So to start with, analysis of that epithelium. So what we did is like we as in our group, we sort of like believe in using human models as much as possible, but not really on the human beings, but using human like tissues or cells in the lab, not to go for rodent or any other animal models as much as possible. We sort of avoid that, right, to get more human relevant data. So with that, like what we did is like we first established this model of growing oral mucosal tissues in the lab. So what we do is like we take the oral fibroblasts, mix them with fibrin matrix, and because the fibrin matrix is the first matrix with which any wound starts to heal, right? And we grow them for a few days, after which the oral keratinocytes are laid on top of them as a confluent monolayer, and we wait for a few days for them to sort of establish a relationship between the keratinocytes and the fibroblasts which are growing in the matrix. After that, what we do is like we culture in a air liquid interface, something like which is very commonly used in 3D cultures, where like the nutrition is coming from the culture medium from the bottom, and the keratinocytes are exposed to the outside environment, be it air or be it saliva or any other environmental factor, right? So basically like nutrition is coming only from one single direction. So this kind of polarizes the keratinocytes and makes these keratinocytes to form multiple layers, and literally forming these stratified squamous epithelium, which is characteristic of oral mucosal tissues, right? And we were more interested in gingival tissues, and so the media conditions were basically like tuned to stimulate the corneal layer formation, and we are also use more of gingival fibroblast and the keratinocytes. And so what you can see here in the histological picture is that from week 1, 2, and 3, is that the epithelium is developing over time. It is increasing in the thickness and also is starting to form this corneal layer on the top. Right, and further we characterize for expression of various basal keratinocyte markers like integrin beta 1, which basically like marks the basal layer, and keratin 14, which marks the whole of almost like whole of the viable epithelium. And the differentiation markers, cytokeratin 10, which is expressed only by the suprabasal cell, which is basically the differentiating keratinocytes, and involucrin, which is expressed in the sub granular layers. All right. So after this initial characterization, what we did is like we established this young and aged oral mucosa equivalence. So this is sort of like a work in progress. Basically we used different oral fibroblasts, but the keratinocytes were the same. So just to understand how just changing the aging of the fibroblast impacts the epithelial tissues, right? So sort of like isolating the fibroblasts or the young and the aged phenotype. So with that, we were able to get this young oral mucosa equivalence and aged oral mucosa equivalence. Right. And so what you see here is the histology of the young oral mucosa and the aged oral mucosa. What you see here is like the epithelium is much more thicker in the younger phenotype compared to the aged phenotype. And this is like substantiated by the quantification of the epithelial thickness, which shows that the aged oral mucosa is thinner significantly. And further, we were also interested to know like whether any differences would be in their phenotype to attract blood vessels, because angiogenesis is part of a wound healing phenotype, right? So we like looked at the amount of VEGF, vascular endothelial growth factor, which has been secreted by these tissues. And what you can see is that the aged oral mucosa is secreting much lesser VEGF compared to younger oral mucosa, which means it could have an implication in the overall wound healing phenotype in the aged tissues, because it may not be having that much amount of ability to attract blood vessels during the wound healing phase. Right. So in conclusion, what you can see is that I think like basically what we demonstrate is that the aging of the oral fibroblast impairs the organization of the matrix proteins, in particular collagen, fibronectin, and fibrillin. And this basically, like what you see is the loss of the complex oven structure, which is present in the younger stage. And so the quality of the tissue is lost, and that itself could have implication in the overall wound healing phenotype, right? And further, what we see is that this aged connective tissue impairs the epithelial morphogenesis of the overlying epithelium. So what we feel is that this in turn could have detrimental effect on healing and the regenerative potential of the gingival and periodontal tissues. And it would be very interesting to know how these tissues respond to various bacterial insult, right? Which is what, like, you have like these tissues being constantly being attacked by the healthy as well as the diseased microbiota, right? So this is something which is ongoing in our work in our lab currently. And so overall, what we have this from these different research, what we are doing is that the elderly individuals may be at a higher risk of impaired wound healing and disease progression, as well as impaired response to periodontal therapy. So that means there should be a sort of a tiered approach when it comes to treating periodontal defects on aged individuals, right? A little more care needs to be taken for gerodontic practice, right? So with that, I would like to thank my collaborators from A-Star Microscopy platform and also Bioinformatic Institute, who are who played a role in really like quantifying all these different fiber orientation and so on. So all these bioinformatics work. And the students and staff involved in this work, from undergraduates to postgraduates as well as PhD students, and the funding sources both from Ministry of Education as well as the National University of Singapore. Right. So with that, I'm happy to take questions. Thank you. Yeah. Maybe I will.
Yes. Hello, everybody. Are you all there? I have seen a lot of comments and a lot of people have joined us. So far, we have not received any questions. What about first you answer the questions that were posted on Facebook? If you recall, there was actually I answered them there, but in case somebody did not see the answers, Dr. Gopalan had asked you in vivo data for further confirmation of this findings. Have you found any in vivo data as yet? Or anyone else basically has done any in vivo work using this?
Okay, so yeah, there has been like previously work which has been done on in vivo cadavers from human cadavers, that which shows that the fibroblast density is lower in aged individuals, and also the amount of collagen fibers are much more thicker, and the finer fibrils are sort of like lost, and the elastin and oxytolin fibers, they are lower in aged individuals. So this is from human data. Of course, there has been a lot of work which has been done on rat and mouse tissues, but but nothing on the qualitative aspect as such, on the orientation of the fiber. So that's where like the work which we try to do is we know that monolayer cultures, like when in research, right, like when we grow the cells on these culture surfaces, culture flasks, they are all growing in monolayer. So but in the human body, nothing is in monolayer, everything is in 3 dimensions, right? And there is nothing in a single cell culture system. There's always interactions which is happening between different cell types, different matrices, and so on. So that's where we always validate whatever we are doing with 3D cultures, and so which sort of like is an equivalent to human tissues, but still like way far off from the real human tissues.
Right. Yes, that is true. Dr. Raghu, I think there are some questions that are coming in. Will you take those?
Yeah, Gopu, it is a wonderful work to begin with, and congratulations to you and your team. Uh, you opened altogether new opportunities in research using the second harmonic generation of the multiphoton microscopy, which is something that I don't think that we have that facility even in Manipal. I think the first of the questions that I have from the postgraduate student is, can you elaborate on studies on cancer-associated fibroblasts?
Okay. Yeah. Again, like how the I think like this is also one of the questions which was posted by Dr. Guru Raja Rao, right? Like how like the skin fibroblast and oral fibroblasts are different, and as such fibroblasts we have like taken the whole research field at least has taken it as for granted that fibroblasts are fibroblasts, but in reality it's not that's the case. Each fibroblast are completely different. They are very site specific. So skin fibroblasts are different from the oral fibroblast. And within the oral cavity, the gingival, periodontal, and the oral mucosa and the palatal fibroblasts, they all are four different fibroblast phenotype, at least minimum of four different phenotype. And so this is in a healthy state. So now like when we take a disease state like cancer associated fibroblast, obviously they are in a different environment which is being challenged by the invading cancer, right, like which is also going through epithelial mesenchymal transition, and that's where like they are invading into the connective tissue. And because of that, obviously the cancer associated fibroblasts, they are different, and the matrix which are laid down by them are different, but somehow these fibroblasts are tuned or programmed to lay down more collagen to sort of ward the invasion of the tumor. But again, there are two different heterogeneity within the cancer associated fibroblast also. Those fibroblasts which are right next to the cancer tissue, cancer invading cancer cells, they are different from which is more into the periphery. So there are a lot of work which is going on to understand the mechanism of the cancer associated fibroblast in the tumor progression, as well as restricting the tumor also. So it's not just a straightforward answer.
Gopu, there's another question from Dr. Shivani. It's a fairly simple question. How do you study the senescence of a fibroblast?
Yeah, hi Shivani. Yeah, it's an excellent question. Like you have senescence of fibroblasts. Obviously, like what we used was most minimalistic concept of just taking the cells from a younger individual, keep culturing them over time, and eventually they age because they run out of their telomere length. And so you call this as replicative senescence, which is a bit of an artifact within the in vitro system. But this kind of thing also happens within the in vivo tissues also, that there is a replicative senescence. And so how we do this assess the senescence is primarily first by assessing how long they take to divide. So when they attain senescence, basically like before they really attain the senescence, it's sort of like it's not something like suddenly one day they attain senescence, right? Like it's basically a slow transition. So in this transition process, what happens is their proliferation rate really goes down. The proliferation index, which is the expression of Ki67, and is going down, as well as these senescence associated transcription factors like P16, P21. These are all like getting upregulated. So that's how like we sort of assess how they are like going towards a senescence phenotype. But of course, if they reach their senescence, complete senescence, yeah, it is very difficult to do any of the assays because they lose their proliferation ability completely. So which means you are restricted to whatever cells you have, like a very few amount of cells. So we do most of the assays just pre-senescence.
Thank you, Gopu. There's another question from Shruti. What's the difference between intrinsic and extrinsic aging of fibroblasts?
Okay. Yeah. So yeah, the replicative senescence is something like it's more of intrinsic aging because it's something like driven by the genetic itself, like the telomere and so on. While the extrinsic aging is more of something like to do with external factors, like even microbial challenge has a role to play in extrinsic aging, right? Like because these constant microbial attack is going to have a lot of oxidative stress, and that oxidative stress would impact the proliferation of the cells and lead the cells towards an aged phenotype. Same way, like the loss of proliferation ability after chemotherapy or radiation and so on. So all these are extrinsic factors which come into the aging.
Yes.
So, Gopu, there are no more questions. I just thought I'll ask Dr. Mandana if we could just summarize Gopu's presentation and if I'm allowed to ask a couple of questions.
Yeah, Dr. Raghu, there is one more question. This is by Dr. Nandini. Any insight into effects of inflammation on fibroblasts?
Yeah, yes. So as I was saying, like the bacteria microbiota also have their effect on the fibroblast, right? So that's true. The various inflammatory cytokines, which are either produced by fibroblasts themselves, and they have a sort of self effect, or by the keratinocytes or even the immune cells. So it's something like which is also a field which is growing recently. It's called the inflammaging. So it's aging induced by the various inflammatory molecules which are secreted by the cells, but all the cells, not just the fibroblast alone. Obviously, fibroblasts are cells which come as a first line of defense in terms of innate immune response, but later on the immune cells take up. And eventually, like these all they have effect on the aging.
That is true. Can I chime in and add one point? And Dr. Raghu, then you can take it. Okay, so as far as inflammation goes, I guess the one of the things that comes into play is the fact that any inflammation also causes the activation of things like the platelet activating factors, and those themselves activate TGF beta. And the whole inflammation process basically causes the one of the basic signs of inflammation which we have, which is a swelling in the tissue, and that hampers the exchange of fluids, and that increases tension. And one of my interests is in biomechanics, and biomechanics of that affects the effect of that stiffness on biomechanics, and how it affects fibroblasts is that it leads to the addition of fibers, basically, because you need stronger fibers and fibers that are cross-linked to overcome that, and which is part of the reason as to what even happens in a way in the long term in oral submucous fibrosis. So that of course is simply because I'm interested in that part. And now we'll just Dr. Raghu, yes, you can you can add in your questions and discussions, and I think then we can have Dr. Guru Raja Rao also adding into whatever is his discussion, and if anything else comes, we'll add it in.
Maybe I'll request Dr. Guru Raja Rao to start with.
Yes, you can.
Can you hear me?
Yes, sir, we can hear you.
Yeah. Thank you very much, friends. Dr. Gopu, it was a very interesting talk. Indeed, we were very much excelled by seeing your presence after a long time. I think I had met you from a couple of years back, and you were just about to step into Singapore before going to do the works. Incidentally, I am also a very great student of, fibroblasts and all these mechanisms for over years in periodontal pathology and healing process. Incidentally, I found that in some literature, there is some amount of scarring also taking place in oral mucosa especially when there is healing taking place in necrotizing ulcerative gingivitis, number one. Number two, also when we do a mucogingival surgery, especially like, uh, the vestibular deepening procedure. These are the only two occasions where we find the presence of scarring. However, apart from that, I have not found any lesions where there can be healing without any scarring, of course. But then I have one small question to ask, especially in people who are predicted for, keloid formation. Now, what is your sense in keloid formation? How is the expression of collagenesis taking place in patients who are having probability of keloids? That was the only question that I would like to ask. Thank you, please. Yeah.
Okay, yeah. I personally have not worked in on keloids, but I've been like following the literature in this area as more of a personal interest. Again, because keloids is something like very restricted to the skin tissues, and doesn't really like happen in the oral tissues, at least to my knowledge. But what has been like seen is that why this particular heterogeneity in the response is also in terms of the difference in the developmental aspects of the fibroblast. The When compared to the skin fibroblast, the oral fibroblasts, they are derived from the neural crest directly, and so that's why we call it during the tooth development also as ectomesenchyme, right? Like, so there is this direct contribution from the neural crest, and so that has an implication on these fibroblasts. And certain Hox genes, which are developmental genes, they are expressed in these fibroblasts, which eventually control the collagen synthesis by these cells, and the way they even remodel the collagen. And so that sort of like seems to be a factor why keloids are not present in the oral mucosa in the same individual who's having a predisposition for keloids in the skin. But for other aspects, like in something like in necrotizing ulcerative gingivitis, or in certain surgical procedures, or even in pemphigoid, the ability of scarring can come up. That's something like which could be because of the pathology itself, or some sort of like aging which is really like happening at a much faster rate. So which is something like which is some open for more investigation. And just like how in submucous fibrosis everything changes like in a very short span of time, right? Like these fibroblasts suddenly become like so much of collagen laying, which is not their natural phenotype. So there could be some other extrinsic factor literally like changing their behavior.
Yeah, thank you, Dr. Gopu. Incidentally, I have a small invitation to you. We are having 25 years of Bangalore Academy of Periodontology. It's going to celebrate the Silver Jubilee in this year. We would like you to also participate and present a small talk like this, in our course of programs. Then I will certainly invite you. Please do accept the invitation at this juncture, and I will extend further to you. Thank you.
Yeah, sure. Thank you very much.
Yeah.
Muted. You have muted yourselves. Mandana, unmute yourself.
Yes, I realized. Okay, sorry. On that issue of the keloids, there is one difference also between the mucosa, oral mucosa, and the rest of skin. Basically, as far as, although it is genetic predisposition, but perhaps, I can't tell you definitely, but this is just my idea, that one of the reasons that perhaps it doesn't happen in the oral mucosa is that the oral mucosa is mobile and extensible. Keloids, even when they occur, are happening in parts of the skin that are tight and across lines of trauma. So both those need to be met. and they are generally not met in the oral cavity, because although we have the gingiva and palate, which are of course tightly or rather immovable, but then they are not flexing either. So there is no line of flexure across, which then would cause that kind of formation. This is my what I have gathered from whatever I have studied. I mean, others can definitely add into that. Yeah, okay. And now I will really stop and I will hand over to you. Yes, Raghu, please take it.
Thank you so much, Dr. Mandana. And uh, just to summarize what Dr. Gopu has just spoken to us this morning. So he's mentioned that the collagen laid down by the aged oral fibroblast was much thinner and poorly organized compared to the young oral fibroblast, where the collagen was thick and interacting. And I think he has done the depth profile analysis, which could confirm that the structural organization of some of the ECM proteins, such as the fibronectin, the fibrillin, is impaired following cellular aging. And the key method that he has used in the present study is to investigate the structural organization of collagen using non-invasive, label-free imaging of live cultures using second harmonic microscopy. And this is a very defining study because it compares the qualitative disturbance in the organization of the ECM. Most of the studies using the Gopu series and others that we have seen in the past speaks about the quantitative disturbance. And for the first time, I think Gopu and his group have shown that there is a qualitative disturbance in the organization of the fibrillin fibers. Congratulations to you for some of the important work that you have documented through your work, Gopu. The only observation, of course, which you have also stated in your paper is that the current study is just limited to one donor. And by continuously subjecting to the subcultures and using that as a surrogate marker of senescence, obviously is something that you would probably consider doing that with two different patients, one from the young and the other from the elderly, so that you do not have to segregate the young and the old fibroblasts through continuous subculturing. So that is something that I felt was rightly mentioned also in your paper. The only thing that I was actually interested was it might also be worth considering using a combined multiphoton microscopy with optical coherence tomography. That is something that you can do because you have also now started with the 3D cultures. So that way, you've got the short pulse, which is actually necessary for multiphoton microscopy, and also the broadband width that will be needed for the high resolution optical tomography. And there are not many studies. So I think if you can use these live cultures and combine optical coherence tomography with multiphoton microscopy, that would be a very good work for you to take it forward.
Yeah, thanks, Raghu, like for wonderful summary, and also like highlighting the limitations of the study and what future work what we are like planning. And so that's the thing of I sort of like believe in whenever like I'm writing a manuscript also is sort of lay foundations for the future work, and also be very self-critical of what the limitations are. Like I think otherwise like we are not saying the truth, right? Like so that's how it is very important to be realistic of what the limitations are and where the future work could be laid down. It could be done by me or someone else, like so that's where like it opens up collaborations and so on. So that open innovation is something which I really like believe in. right? Okay, so and with that, like moving on to their thing on comment on combining OCT, the optical coherence tomography, and two photon microscopy. It's something which is doable. Yeah, yes, we had like considered the OCT as well, but somehow like the resolution of optical coherence tomography at at a micron level is a bit of an issue. It's more on a millimeter scale than a micrometer scale, and so that was like the way like where we were like pivoting, like where to take a step, and so we sort of like inclined towards two photon microscopy at that time. But definitely yes, that's something which is uh, we can consider to combine optical coherence tomography and two photon microscopy. And to add on, we also like tried one more thing which is called photoacoustics, which is also again used in dermatology field, especially for visualizing the cancer tissues, as well as mainly melanin containing tumors, right? So because the melanin has a completely different vibrational signals, as well as same way, like I think even in cancers they use it for visualizing the uh, blood supply, because the oxygen content in hemoglobin is different and so on, so they can visualize it. So we also tried for photoacoustics for these cultures using for we also like on another study we were using melanoma as in vitro melanoma cultures, and then we used photoacoustics to really image that. But somehow like optical coherence topography, we somehow like we never did it, but like it was always in the back of mind.
Dr. Gopu, there's one more question from Dr. Vanaki. He wants you to explain about the fibroblast heterogeneity concept.
Okay. Okay, so this particular concept of fibroblast heterogeneity stemmed from the fact that initially people were thinking that fibroblasts are fibroblasts, whether you take them from a skin or lung tissues or oral tissues, nasal tissues, it doesn't matter. They all had the term fibroblast attached to it, and it was all like used literally like exchangeably, that any fibroblast is the same, right? So but then eventually like the research started to people started to understand that there was some site specific uh, differences. Like for instance, when we take the oral epithelium and plant it onto the dermis, right? Like what happens is that these tissue, like in the fetal stage, right? These tissues then they start to have ability to induce hair follicle formation. The same way, like you do the other way around, there can be like formation of teeth. So that's something like which was done in a very early stages, and they found that this instruction is basically coming from the connective tissue, the fibroblasts, which are like instructing the overlying epithelium to say like what they need to form. So the fibroblasts were holding the key. So that means like one fibroblast is not equal to the other fibroblast, so there is some differences between them. So that's the concept of fibroblast heterogeneity is all about. And so each tissue has its own connective tissue and its own set of instructions. So sort of like you can say that function determines the form. So the like just like how the gingival epithelium, palatal epithelium is cornified, while that of the lining epithelium of buccal mucosa is not, right? Like so that's also probably something to do with the connective tissue. The underlying connective tissue is different also. In the lining mucosa, they are much more loose and elastic, while in the gingiva or palate, they are much more hard, right? Like so, the collagen, the extracellular matrix is different. So probably that also plays a role in the overlying epithelium, other than just the mechanical trauma which these cells are experiencing. So that's sort of in a nutshell about the fibroblast heterogeneity, that there are differences between different site, and that is being brought about by fibroblast as one of the key cells which are driving it.
I think
there's one
we
more
have
question.
time for one more question, Mandana. There's a question from Shivani,
Okay, we'll
which
take that
is
as the last one, I think.
yes, which is uh, the difference between fibroblasts of oral submucous fibrosis associated with oral squamous cell carcinoma and fibroblasts of oral squamous cell carcinoma. Gopu, is there any difference between the fibroblast of OSF associated with OSCC and the fibroblast only with OSCC?
Definitely, there must be a difference. Otherwise, like I think that it doesn't like, but means by now, I'm not aware of a literature as such. Probably I have not
Raghu can answer that better.
So one of the things that Shivani, you have to know is there is something called senescence-associated secretory phenotype. So these are the pro-inflammatory fibroblasts because senescence is normally considered to be a tumor suppressive mechanism. But then some of the components of the senescence-associated secretory phenotypes includes the interleukin-1s, interleukin-6, interleukin-8, and the GRO alpha. So these are all some of the molecules that are associated with the fibroblasts that are associated with oral submucous fibrosis and oral squamous cell carcinoma, which have the ability to promote tumors because these are pro-inflammatory. I think if Gopu agrees with me, that's the difference between the senescence, I mean that the normal fibroblast and the pro-inflammatory fibroblast that you normally see in squamous cell carcinoma and OSF. So with that, I think Mandana, we are done with all the questions, and over to you, please.
Yes, thank you, Dr. Raghu. Thank you, Guru Raja Rao sir and Dr. Sriram. I think that was a wonderful presentation, and you went, I would say, well beyond what you have your immediate area of research, and we answered a lot of questions. And I think that was the basic idea, was to really generate discussion and to introduce new ways that then can be applied across different fields and areas of research. Your work was wonderful. I have one thing to ask you. Now, with all this wonderful technology that you have, is there a possibility that people from here can collaborate with you and get to use some of it?
Yeah, yes, it is possible. Like, I don't know, like there is some limitations in terms of travel, right? So that's the biggest factor which is there. But of course, like there are ways in which like we can collaborate, and also like and okay, talking about even these microscopy technologies, right? Like it's not only we can use two photon microscopy on live tissues, it can be done on paraffin sections also, which means if there is a restriction in terms of like people from traveling from around, in terms of both in the present state as well as in future in terms of say monetary aspects and so on, we can always like ship these tissues or the sections around, right? And then we can do our part over here, and then we can have, I think that's how it has been done previously as well, with many international collaborations where different partners come to play different aspects.
Yes, so
And so I'm very happy to uh, and we're very much open for any collaborations.
that is wonderful. That really makes a difference. And I hope everyone was listening to that last bit. Everyone who is really interested in continuing this work. And yes, thank you so much, Dr. Gopu. That was really a very nice presentation. And I'm sure you will have many people who will get to you for further work. And now we have had, of course, a lot of our regulars who have been with us. Dr. Nandini, Dr. Bhavna is back from her holiday, and so next time she'll probably be helping us out. Dr. Kavita, Dr. Rastogi, Dr. Meghanand Nayak, Dr. Sangeeta Palaskar, Dr. Metgood, and Dr. Kavita Rao. Dr. Nagasudhir, Dr. Manjuri, Dr. Madhura, Dr. Arpan Shah, Dr. Shivani, and I think I saw Dr. Hazare somewhere there.
Yeah, a lot
Yes,
of old friends, all like all,
friends.
yeah,
Yes, I
yes.
think they have all come to see you, and yes, it's been great, and everyone
Yeah,
has.
I've been missing them all a long time.
So anyway, they all saw you, and well, hopefully soon you will get a chance to see them. We also had Dr. Vaniki with us, and that was very nice of all of you all to attend. And I'm sure there are a whole lot who have not messaged us, so we don't actually know that they're there. But that has been nice. And now I have to just do one little share once.
Keep up the good work, Gopu.
Yeah, yes, thank you very much. And yeah, yes. Oh, okay. Thank you very much. Yeah, it's been a pleasure for me to share from this part of the world, like what is possible. And at the same time, I'm very happy for to working together for any of the work in the future.
Yes, wonderful. Thank you so much for being with us, and for the presentation. It you actually started this ball rolling, of the research hour. And yes, Priya, thank you so much too for all your back helping in the background. But it's a lot of difference it makes that you're there. And with that, I shall say thank you and bye to everybody. Please, I have one more announcement. This week, we are going to be having out of our regular schedule meeting, that's on the Friday evening, because we are starting with our Beyond Borders series with Dr. Keith Hunter, who is going to be talking about CEOT. Please don't make a mistake and turn up on Tuesday and expect him to be speaking. He's speaking on this Friday evening, so just go to the YouTube and mark the time. So we will see all of you. Thank you so much. If you have enjoyed whatever you have been seeing so far on this channel, please subscribe, please share, let others know it exists. It is our combined movement, and I hope to see all of you. Thank you so much. Wonderful being here. Bye.
All right. Thank you very
Bye.
much.
Bye.
Have a nice day.
You too. Bye.
Thank you, sir. Thank you, Dr. Mandana. Thank you, Gopu. Have a nice year, all of you.
Yeah, yes. You all too. Yes. Thank you.
Bye. Bye.